Samet Sehat has said, he's a very well-known all over the world. He has been traveling around, and as you know, he's one of the most experienced surgeons with minimal invasive surgery. This is a honor to host this day, Steve, with us, trying to explain why it's important, the minimal invasive surgery in neonates. Neonates, it's a very special patient, is the way or the reason that pediatric surgery was born, and minimal invasive surgery has settled down very well since a long time ago and in many places, but still there are many hospitals that need to introduce this kind of surgery. So it is my pleasure just to introduce Steve to present his talk about minimal invasive surgery in neonatal surgery. Thank you.
Well, thank you, Juan, and thank you, Sammy, for the very kind introduction. It's a great pleasure to be with all of you, at least this morning where I am. I know it's different times around the world. And I think this is a very important topic, and it's a pleasure to talk on it. I think doing minimally invasive surgery in neonates takes a special skill set, sort of a special mindset, and as well as special instrumentation. And so I think it's important to think about all those things when we talk about this. But I do think the benefits when we operate on a neonate minimally invasively are extremely long lasting. We avoid a lot of the late complications of doing surgery on a neonate. If we're doing abdominal surgery, we avoid a large part the risk of adhesive bowel obstructions of forming later. And in thoracoscopy, we avoid the risk of developing chest wall deformity, and we'll talk about that more later. So I'm going to go ahead and share my screen with you. We're actually in the middle of a big snowstorm right now, just ending. So we have a lot of fresh snow outside. Unfortunately, most of it fell in Denver and not the mountains. But if any of you are ever in the vicinity and would like to visit, we'd love to have come visit my hospital, the Rocky Mountain Hospital for Children. So this has really been something that I've been working on for over 3 decades. We started operating minimally invasively in neonates really in 1992, 93, and have been trying to refine this. And I think basically all the procedures we perform now, with rare exception, are performed using minimally invasive techniques.
Excuse me, Steve, are you sharing the screen?
I thought I was. Let me get back, see if it didn't share. All right, sorry. Okay, sorry, my bad. Okay. Now can you see?
Yeah. Okay, that's right.
All right, sorry about that. So anyway, let's go back. This is a picture of my hospital. This is what I'd usually rather be doing than anything else. And this is what it looks like in the fall for those of you who don't like snow. And again, this is just shows the evolution of trying to do a less invasive incision, a muscle-sparing incision in the chest, to doing mini thoracoscopy, to doing everything we do now laparoscopically. Instrumentation is really a problem, and I know for many of you, you don't have the benefit of having the instrumentation that I do. I must admit, I get access to almost everything I want in terms of miniaturized stuff, but trying to perform minimally invasive surgery in a neonate using, these are rather old pictures, but a 12mm stapler and the smallest at the time was a 5mm vessel sealer is difficult, because they don't really fit in the spaces we have to work in. And so I think it's important, and we're trying to make them available, to get the right size instruments. And so I think if you're going to operate in neonates, then you need to have smaller, shorter scopes. My workhorse scope is a 4mm, 30-degree short scope, basically about 20 centimeters in length. And the reason is, one, obviously a smaller diameter, so we have a smaller incision. We use a 4mm trocar for that. There are also good 3 mm scopes, but often they give you a more reduced frame of view, and they're more delicate. So I think for most people, a 4 mm scope is a good compromise. But the short length is very important, because if you operate with a standard 5 mm length scope, then you end up having to be very far away from the baby as you operate, because the scope will hit you in the belly. And so having a short scope that your cameraman can work is very important. And then I think short instruments are very important. Again, we want to be ergonomically precise. And when we're operating with long 5 mm instruments or even long 3 mm instruments, we're sort of out here. And you really want to be here where most of your movements are just with your wrist and your fingers. And again, it's all about ergonomics. And that's something to keep in mind as we go through this talk. So I have a set of 3 mm instruments that are 18 to 20 centimeters in length. We use small trocars. We use high definition digital cameras. I know a lot of people are using 3D now. I don't personally do that, just because the scopes tend to be bigger. And also, I've been doing this so long that I see in 3D. I can tell by the shades, but that may be something that comes more important. It's important, I think, to have vessel sealing technology if you can get it. I understand that it's very difficult. I think the use of monopolar cautery in babies is dangerous, where there's a lot of energy spread that we don't see. And we should try to get away from that, because I think there are a lot of undiagnosed injuries. For instance, operating down in the pelvis, doing a pull through for Hirschsprungs, if you're using a hook cautery, which I used to use, we don't really know how much damage there is to the surrounding innervation that could cause problems later in life. And then we need things like small staplers and clips. So this is just a list of all the procedures that we perform using laparoscopy in neonates and infants. We wrote this series up many, many years ago, the initial one. And then these are the thoracoscopic procedures, what we perform. And basically, you can see that every procedure that we do as a pediatric surgeon, we have done this. The only things that are really difficult is if you have extremely distended bowel, so that the abdomen has no space, or if you have a giant mass that you just can create no space to work in. And I thought I'd share with you, this is just to kind of really hone in on the smallest of patients. When we talk about this is a series that we put together of patients under 2.5 kilos, sort of the smallest of the small, to talk about the differences in doing neonatal surgery. So this is my operating room. I'm very fortunate in that I have a dedicated minimally invasive operating room. You can see we have a lot of different monitors that we can place where we need them. The room is really set up to do minimally invasive surgery. Again, you can do this if you just have a tower, but it helps to have dedicated rooms and dedicated equipment. Insufflators in neonates, it's really a problem. It's difficult to get an insufflator that's sensitive enough to deal with the small spaces that we're dealing in. I think when you're doing, I differ a little bit, I think, than many in Europe, because I tend to operate at higher pressures. I know many people in Europe operate at pressures of 6 to 8, but we often in a neonate will operate in pressures to 10 to 12, because if you can't see, you can't do it. You can't operate, and the procedures take longer. And so, and we've had no problems in terms of the thing people worry about is, cooling, hypothermia, hypoperfusion, CO2 embolism. We have not seen any of those. And we probably have the biggest series of neonatal laparoscopy in the world, but you have to work with your anesthesiologist. But again, if you can't see, you can't operate. And my operative times tend to be less than most. And I think, honestly, part of it's that I just can see better because I operate at slightly higher pressures. When we do thoracoscopy, we usually start at a pressure of 4 to 6. You can go up as high as 8 to try and get the lung to compress, and then we'll back off. And then for certain procedures, we like single lung ventilation, but not for routine things like TEF and other mediastinal masses. And again, here's all the procedures that we've performed in the smallest babies. The first endoscopic procedure I performed, I'm sorry, this video is not working, was a laparoscopic pyloromyotomy, and people were worried about air embolism, hypotensive acidosis, but there actually has been a paper that came out a number of years ago that actually showed a laparoscopic pyloromyotomy was preferable. and better outcomes and better for the patient than doing an open pyloromyotomy. And that was printed in The Lancet. Does it make a huge difference whether you do your pyloromyotomy laparoscopically or through a supraumbilical incision, ring incision? Probably not. But what it does matter is if you're going to operate and do complex procedures in neonates, then you need to operate as often as you can in small spaces. And so for us, at least, pyloromyotomy is something that we do a few times a month. It's a relatively simple procedure. Honestly, it takes 5 to 10 minutes once you get good at it. And it gets you and your team used to operating in this small space so you can do more complex things. So I think it's very important that procedures like this are done laparoscopically so that you build up your expertise with this. And then obviously this is 3 generations in one family. Grandpa, mom, and baby all have pyloromyotomies. You can see grandpa's scar is pretty bad. Mom's is right up in here. And the babies, you'll just have to trust me, you can't see the trocar sites. The other problem is that to try and get people to make us things we need, one of the things that didn't show in that other video is when I first started doing a pyloromyotomy, I was using a little arthroscopy blade with a retractable blade. And unfortunately, the company discontinued it and we didn't have anything. And it took, so I helped Storz design a replacement blade so we didn't have to use a Bovie. But it took over 4 years to get it made and then get it distributed. So because we're a small market, it's hard to get the instrumentation that we need to do things minimally invasively. So, one of the most common operations I did, we're not doing as much, was a fundoplication. I live in a hospital where we're very concerned about bad reflux in neonates and infants. We're worried about the long-term respiratory complications of those patients. And so this is the operation that really taught me to operate in a neonate. Now, this is the smallest baby I've done, 1.2 kilos. I'm not saying, in general, this baby just would not feed, couldn't tolerate it, had a hiatal hernia. And so we did a hiatal hernia repair and a fundoplication, and the baby was able to grow and do well. But this is the operation that really taught me to sew, and it's important to learn how to sew. More commonly, this is duodenal atresia. We now perform all our duodenal atresias laparoscopically, and this is kind of what it looks like. You can see the view here and the initial anastomosis. Again, the smallest baby I've done this in is 1.2 kilos. Here you can see the trocar sites. But just to show you what this looks like a little bit, this is a baby who had duodenal atresia and a LADS procedure. And we'll just kind of run through this. Here you can see that we're using the 3mm vessel sealer to mobilize, get down to the atresia and the duodenum. This child also had a malrotation, so we're using that. If you don't have this, you can use other devices. Again, this is a fairly small baby, 2.5 kilos, so it's nice to have a safe energy device to use in this space. I used to use monopolar cautery. You can do that if you're well aware from the bowel. But you can see how we're taking down adhesions. Now you can see I'm running the bowel because it is a malrotation. And the key to doing a malrotation laparoscopically is that you need to run the bowel in front of the camera, not chase the bowel around the abdomen. So here you can see I'm very steady in where I'm focusing the camera, and I'm just running the bowel and unwinding it right in front of myself so that I don't get lost. The other thing that we do when we operate in neonates, now here you can see this is the large dilated second portion of the duodenum. Here's the distal portion. You can see that I use transabdominal wall stitches to act as retractors. That way we can avoid putting in more instruments. Again, these are 3mm instruments. You can either put them through stab wound incisions, or I tend to use 3mm trocars if I'm going to be exchanging the instruments frequently. And so here you'll see I'm putting a transabdominal wall stitch through the anterior abdominal wall, and I'm going to use this to set up my anastomosis. So I go in the apex of the anastomosis. So this is the transverse duodenal incision. And then I go in the apex of the longitudinal incision in the distal bowel to line up the anastomosis. And I don't do a diamond shape anymore. I used to do that in open surgery. I don't think it's necessary. We just do a side to side. But again, it's the transverse against the apex of the distal segment. And now I've lined it up, and now I just put my stitches through the abdominal wall, and I can simply, here you can see I'm going to run the back wall, so I can see it very well. This retraction suture is holding up the anastomosis for you very nicely. And I'm just going to run this down and run the back wall. When I first did this, I did all the stitches interrupted, but I realized that took more time and it wasn't really necessary. And so now I just run the back wall, and then I'll take a second stitch. I'll tie this off at the counter apex. And now I'm going to take a second stitch and run the front wall. And so I can do, you know, the anastomosis with two separate sutures. Here you're seeing me run the front wall. And here we have the end of it. What's even more simple and faster now is because we have a 5mm stapler, we're actually doing this anastomosis using the 5mm stapler, aligning it the same way, just making two anerotomies on the proximal duodenum and the distal jejunum or duodenum, and inserting the stapler. And that's what this looks like. Here you can see the stapler in, and we're just doing a side-to-side anastomosis. And then the only thing we have to do is sew this enterostomy. And again, many of you don't have access to this 5mm stapler, but if you do, we've presented now a couple series of this. And in fact, I think there'll be a series presented at ESPES this fall. And this is our follow-up with that. Usually, I was getting an upper GI in all these patients at 2 months. I don't do that anymore. We've had only one delayed stricture that isn't shown here. A few patients have needed anti-reflux medications, but they're all doing well. Even intestinal atresias, this is a proximal intestinal atresia, and maybe your skills aren't good enough initially to do the anastomosis inside, but what you can do is you can go in and find the site of the atresia, and then you can bring this up through a separate little muscle-sparing incision and do your anastomosis outside the abdomen. It's a good way to build up your skills and learn about this. And then this was a very interesting case I'll share with you. This was a proximal jejunal atresia. You can see it's quite dilated, no distal gas in this baby. And this is how we set it up. So the baby's down at the foot of the table, and I stand between the baby's legs so that I'm working in line. So we often put the baby at the end of the table. Again, ergonomics are extremely important. 2 3mm instruments and the 4mm scope and the umbilicus. One thing that's very important in neonates, I believe, is that you should never go through the center of the umbilicus when you're putting in a trocar. You run the risk of injuring the umbilical vein and insufflating into that and causing a CO2 air embolus. So I use a Verres needle approach. I know many of you use an open approach, that's fine, but I always go in the infraumbilical ring incision. That way I can avoid the umbilical vein and hopefully avoid that complication. So here you can see there's dilated bowel, and here's the very dilated bowel, and here's the atresia right here. So that's a proximal jejunal atresia. And then I'm going to go ahead and run the distal bowel. You can see the appendix coming up here. But this child had an apple core or apple peel deformity. The bowel was just wrapped around this single vessel, so we ran the bowel. And then what I did was I mobilized this very dilated jejunum. There was about 8 centimeters of it, and I thought it would be quite dysfunctional. So I got rid of most of it. And then I resected it. Now, again, I had the benefit of having the 5mm stapler, but I was able to use that to resect the majority of this very dilated jejunum. And then I ended up with sort of a pouch, kind of like when you do gastric bypass surgery. I ended up with this proximal pouch just distal to the ligament of Treitz. So here you can see that pouch. And then I was able to do, here's the distal jejunum, here's the proximal. I made an enterotomy here, and then I made an enterotomy in the distal segment, and I was able to do a side-to-side, here you can see just a side-to-side anastomosis with the stapler. So this allowed me to do this very quick. relatively easily. Again, if you didn't have it, you could just do a side-to-side hand-sewn anastomosis like I showed initially with the duodenal atresia. And then all you have to do is close the enterotomy. And this baby was actually, amazingly enough, here's the specimen. So then we have to get it out. So I opened it up to decompress it. And then I just pull it out through the trocar side. Here's incisions post-op. And he was able to start eating on post-op day 5, which was quite remarkable. You can also, like I said, you can go find your atresias, and this is distal iliotresia, so very little room to operate in the abdomen because of the dilated bowel, but we just exteriorized this and did the same kind of side-to-side anastomosis. Necrotizing enteroclysis is another place. So this is, I don't use it so much in acute perforations. Usually those babies are small, their abdomens are very distended. I know some surgeons like Arnaud Bernard has done a lot of work with laparoscopy in this to determine if there is a perf, but usually if it's a bad perf, we just do an open procedure. First, you always want to do what's best for the patient, but this is a case where they had NAC, then they developed a stricture, and we went in and mobilized the stricture and then resected it. Initially, when I did this, I would mobilize this, bring it out through a small incision, do the anastomosis outside. As my skills got better, I've been able to go in, identify the stricture. As you'll see here in a second, we're running the bowel looking for the stricture. There was a Meckel's. So here you can see that there's a walled off perforation and stricture. The bowel had perforated on the spleen. I'm using, again, the vessel sealing device to dissect this safely off the spleen. And then I'm able to get to the injured area of the bowel, which is right here. And we'll just resect that. And then we're going to do this anastomosis intracorporeally. So I was able to mobilize the mesentery using the vessel sealer. Again, this is a small space, but the 5mm stapler sits in there. If I didn't have the stapler, I would just cut the bowel and do an end-to-end anastomosis, which is pretty straightforward. This just makes it a little easier. Here you can see, again, I'm taking down the mesentery, dividing the bowel distally. And then I'm just going to set up my anastomosis to do a side-to-side anastomosis, again, using a transabdominal wall stitch to help me align that. And now I've got the bowel side to side. I can make 2 small enterotomies and put in the stapler and create this nice big anastomosis. One of the advantages of using the stapler is that we end up with a much bigger anastomosis than if we do a hand-sewn end-to-end. We've shown that in animal studies. And then that was just taking the Meckel's. Intestinal duplications is another nice case. This was diagnosed prenatally. We let the baby grow for a little bit, then we did it, but it's the same basic idea. We're just going to take the mesentery, divide the bowel proximally and distally. Again, if I didn't have the stapler, I would just cut the bowel and do an end-to-end. And if you don't feel you have that skill set, you can mobilize this and then bring it out again through a muscle-sparing lower quadrant incision and do the anastomosis outside. But all of these things, you could try to do them all this way. It builds up your skills. And here you can see we're going to do that same side-to-side anastomosis using the stapler. We get a nice big 2.5 centimeter anastomosis, transabdominal wall stitch aligning the bowel for us. And so that really helps. And then this is our specimen. This is the thumb of a number 8 glove. We'll use that to bring the specimen out through the abdominal wall. Neonatal hypoglycemia, I won't talk much about this, but you can do a near total pancreatectomy for this if you need to, or resect the tail of the pancreas if you had an adenoma. Laparoscopic pull-through for Hirschsprungs, we do all our procedures this way. I think that this is an operation. I know a lot of people do transanal anastomosis, just transanal pull-throughs, but I think it's been shown that actually the outcomes are worse. You have a higher incidence of incontinence and sphincter dysfunction if these operations are done completely transanally. So we always go in, find the transition zone. I didn't show it, but I do a biopsy laparoscopically, send that off to make sure I have the right transition zone. And then you can see I just dissect down all the way down to the pelvic floor. Again, I used to use monopolar for doing this. Now I use this 3mm sealer. But this part of the operation is very simple. It takes 20 minutes. It's really very, very quick. I think it's much easier than doing all this dissection transannually where you're trying to come up. And then we avert the anus, we avert the dentate line so that we can see the dentate line here. And then we make you can see we make a small dissection, getting that submucosal plane. But because we've done all this mobilization, the bowel comes out to us. And so the one thing you'll notice when I do this operation is I never put retractors in the anus. And I think a lot of people, when they try to do this completely transanally, they put in retractors and they end up stretching and injuring the external sphincter, which is what you end up relying on for continence in these patients. And so I think by doing this operation laparoscopically, the abdominal and pelvic mobilization laparoscopically, one, again, you build up your skills to be able to do, complex neonatal surgery. And two, you never have to put a retractor in here. So I think when you do this laparoscopically, and it's been shown in studies, you have less external sphincter dysfunction. And eventually, you can see it starts to roll out at you as we stay in this plane. Again, never a retractor inside. And I go to where I meet my dissection from the inside. And then I always divide the muscular cuff posteriorly so we don't, if you don't do that, you can get recurrent enterocolitis. And now you can see I'm just pulling the bowel out. And if there is some vessels I'd need to take to mobilize it more to get to where my biopsy, where I have proven ganglion cells, I can do that easily. But again, all outside the anus, never a retractor in the anus. We also do this for anorectal malformations. So this is a boy with a prostatic urethral fistula. So again, we just dissect down right onto all the way on the bowel, just staying on the bowel wall. So we're not injuring any of the surrounding nerves. We don't risk injuring the ureter. Again, a transabdominal wall suture, I'm going to use it to retract the bladder up out of my way and give me better exposure. And we just carry this all the way down to the fistula. Here you can see the fistula showing up. And I've tried a number of different things for taking the fistula. And honestly, my new favorite thing is to take this with the stapler. And we've written this up. Again, if you don't have the stapler, you can suture ligate this. You can use endoloops. You could even use a clip. But I wouldn't use vessel sealing. I worry about clips coming off. But some people just cut the fistula and leave it and say they have good results. What you don't want to do is you don't want to leave a portion of the fistula because you don't want to end up with a diverticulum. And I think some people who do this don't follow this all the way to its insertion. And so you don't want to leave a big diverticulum. But here you can see that staple line, it's almost disappears because we're so close to the urethra. And then once we're through, we come to the bottom, we stimulate the anus, we can see the center of the external sphincter. I make a small, just slightly larger than 1 centimeter incision. And then we're just going to dissect just through the external sphincter. We can stimulate that, make sure we're right in the center of it. And then I use these dilating trocars to come through that. And I look laparoscopically, and here you can see the levators. You can tell that I'm in the center between the two. And it's been shown with CT and MRI studies after this that actually we're very close to being in the center of the sphincter complex and between the levators. So you can visually see where you're putting it. We're just going to go up and grab and pull down the colon, and then we're going to do our external anastomosis. And we're now starting to use ICG in these cases to check perfusion after we've done it. Here you can see we're getting rid of the staple line, and then we're just going to do an end-to-end anastomosis. And you actually end up, and then I'll come back in and do some hitch stitches. I'll hitch the neorectum to the presacral fascia to try and help prevent prolapse. And I just put a couple stitches. And you can see the anus ends up looking incredibly normal. You can't tell these kids have had surgery. This is what it looks like after. And this is just to show you, people say, well, can you use staples on the urinary tract? Do you leave a diverticulum? And this is to show, this was a baby we did, and you can't even see the fistula opening. We get so close, and the staples are exteriorized from the urinary system. Diaphragmatic hernia is also something we do. I'm not going to spend a lot of time on this, but we approach these all thoracoscopically if the baby's stable. If the baby's very sick, if the baby's on ECMO, if the baby's on maximal pressors and ventilatory settings, then I don't do it. I do it through a subcostal incision, and I just do it in the nursery. The babies are too sick. But if they're stable, they're on an FiO2 of around 50%. If they're on NO, that's fine. If they're on an oscillator, that's fine. But again, a lot of people did this operation. This would be the only advanced procedure they would do, and on very sick babies. And I never quite understood that. But we've had good results. I think people have noted a higher recurrence rate. And I think, honestly, that's just because people do a bad job with this. They do it under too much tension. They don't injure you have to be sure and burn around the muscle to make sure that you cause healing. And so this is a case that we do, but limited. I'd say 80% of the CDHs we do thoracoscopically. In terms of thoracoscopic procedures, again, you don't need single lung ventilation, except I think it's helpful when you do a lobectomy. We do a tracheal intubation, and we use CO2 to collapse the lung. Here's an operation that we do that I know a lot of centers don't do. This is a PDA ligation. This is done very nicely thoracoscopically. You can see these extremely well. We just go in, we're just using CO2 to collapse the lung. We're not using a right mainstem intubation. Here you can see, I can see the ductus extremely well. And the key is obviously dissecting away the recurrent laryngeal nerve as it comes around the ductus. But you actually see it so much better than you can even in open surgery. And then here you can see, again, the ductus very well. You can see the nerve showing up right here. And then I'm just going to put a clip on it. And just to use a single 5mm clip. I wish we had 3mm clips. No one's made them yet. So that's the really limiting thing, is trying to get this in there. It's hard to put a suture around this because of the angles and the small right angles, 3mm right angles we have, but a clip works extremely well. So this is when we do TEF or TOF repairs. We did the first one in the world in Denver in 2000. So we've been doing this now for almost 25 years. I haven't done an open TEF repair in the last 23 years. And this is kind of what it looks like. This is just a quick video. And people approach this different way. Many people don't take the azygos vein. I like to take it just to get out of the way. Some people think you have a lower stricture rate or a lower leak rate if you don't take the azygos. I don't think that's true. Darius Petrowski, who is an excellent surgeon and has done a lot of these all over Europe. He doesn't use any energy when he's doing this. Again, I do. In larger babies, I tend to just clip the fistula. So here you can see the fistula right there. The beautiful thing about thoracoscopy is you can see we're right on the back wall of the trachea. The real key to this is mobilization of the upper pouch. And if you have a longer, if you have a longer gap between the two ends, this is where you get your length. You can mobilize the upper pouch all the way well up into the thoracic inlet, and you can do it under direct vision. Once I've mobilized the upper pouch, then I cut the fistula. And again, here you can see the back wall of the trachea and the bifurcation. So our clip is right on the back wall of the trachea, and it's important not to leave a big pouch. I've had to go in and resect a number of pouches where other surgeons have left a big fistula there, big fistula pouch, either thoracoscopically or open, and that acts as a sort of a septic tank where bacteria can grow. And then we just do an end-to-end anastomosis. And this is the hard part, sewing in this space. This is a very small space. It's about 2 square centimeters. And if you want to be able to do this, then you have to practice. You have to train to learn how to sew in this space. The other thing is, in general now, I don't leave transanastomotic tubes, and I don't leave chest tubes. It's been shown that a transanastomotic tube, you have a higher stricture rate, so we don't leave them. I only leave them if I'm doing a really long gap and I'm worried about the tension. And this is our series that we did. And again, very low aortopexy rate. We don't see a big problem with that. I know some centers are doing prophylactic posterior tracheopexies. I don't agree with that. I think it's a mistake, especially considering that we've done this large series of patients and don't have that much problem. And then CPAMs, but you know, this is one of my favorite operations. I believe strongly that these should be resected. I have a whole nother talk on that. We won't get into it. I know many people are watching these. I think that, oh, I'm sorry, these videos aren't going to play. But we use vessel sealing on the vessels and staplers on the bronchus. And this just shows you what it can look like. This is a left lower lobe CPAM in a 6-week-old. I think this baby was under 4 kilos. But this is what it looks like. Here you can see this very complete fissure, but I use vessel sealing to take the fissure. Where there we're exposed to pulmonary artery to the lower lobe. And you can either use vessel sealing on this. If I do that, which I do most of the time, I come down to the segmental level and take it. In this case, because I was able to get right at the main trunk and none of the branches came off until it went into the lung, I just decided to use the stapler. Whenever I use the stapler on a pulmonary vessel, I always make sure I have proximal control. I always anticipate failure. But again, I would normally just use vessel sealing to take this. Once we've taken the artery, now we can expose the pulmonary, the bronchus to the lower lobe. When I would do this open, I would take the artery, then I would take the vein, and then I would take the bronchus. But because of how this sets up, and again, I'm standing at the patient's front, looking at the patient's back, the ergonomics of it set up such a way that the bronchus actually is right under the artery. I use that to help me dissect it out and to get on with the procedure. So we've taken the bronchus, and then the last thing we'll do is we take the vein. So in this case, this is very unusual. I'm able to use the stapler on all 3 major structures, the artery, the bronchus, and the vein. Normally, I would just use it on the bronchus and sometimes the vein. And then I like doing this operation early. We have 185. We just presented this at IPEG this summer, and I think they do quite well. And then again, rarely we will take the tower up into the NICU. So this is, again, our patients under 2.5 kilos. Only a few of these operations had to be converted. There were very few intraoperative complications, and the patients tolerated it quite well. People are worried about giving anesthesia to these patients, but I think there's a lot of data to show these patients tolerate this procedure extremely well. This was a paper that came out of Great Ormond Street at the time, where they questioned hypercapnia and acidosis during repair of diaphragmatic hernias. The problem is that they were using high CO2 pressures and they were taking excessive amount of times. You don't need CO2 when you fix a diaphragmatic hernia thoracoscopically, but there's some very nice studies that came out of Utrecht that show using a NIRS monitor that actually you didn't have significant hypercapnia or acidosis when you did thoracoscopic procedures. So I think it's a non-issue if you do these right. And there's a lot of data out there that's important. And then I think also we've shown that that doing a thoracoscopic TEF repair is as good or better, and you avoid the musculoskeletal deformity. And obviously, the cosmetic results are significant. And while none of us tend to see scars like this, I do still see some kids who come in. And here's a young lady who had a thoracoscopic TEF repair as an infant. She came to me for hernias. She has a great scar. It's not bad, but when you really look at her closely, you can see that she's got a wing scapula and some chest wall deformity. And I think most of us would think that this is an excellent result. This is a young man who had a lobectomy at another center as an infant and came to my chest wall clinic, and you can see he has significant chest wall deformity from that thoracotomy. So I think, many of the needs we need, we do need better insufflators. We do have 3mm instruments, 3mm trocars and skills. You really have to work on your skills. It's important to practice. There are a number of great trainers out there now. People are getting more and more clever all the time about how to train to do these operations. And I think that's important. Suturing is the most difficult task. But I think it is safe in neonates, certainly. And in our center, down to a kilo, each center needs to decide what they're comfortable with. I think it's important to have the right instrumentation, but many of you are very good operating with instruments that I would never use. You're excessively skilled and very clever, and so I applaud you all. I'm not that skilled. I like to have the instruments that can help me do it. And it's very important to work closely with your anesthesiologist. And if you do, then it's an amazing thing. And for the young surgeons in the audience, I always like to share this quote, and it's that a master of the art of life draws no sharp distinction between work and play, his labor and leisure, his mind and body, his education and recreation. He hardly knows which is which. He simply pursues his vision of excellence through whatever he is doing and leaves other to determine whether he is working or playing. To him, he always seems to be doing both. And, you know, I have to tell you that's true for me, is that I had yesterday we did some amazing cases in the OR, and it's almost as fun as getting to ski fresh, deep powder. So anyway, thank you for your attention. I ran a little long, I'm sorry, but I'm happy to answer any questions that you might have.
Thank you, Steve. Thank you so much. I think it was very clear. It was a very nice overview of all the things that you are doing in neonates, and it's great. So we are going to start with the questions. There are some questions that the people are doing, and I asked to the people to ask more if you want. The first question we have for you is regarding duodenal atresia. What type of anastomosis are you doing right now? Duodenostomy, or also you can do duodenojejunostomy?
So I do a duodenostomy. I know, to me, it makes, what I worry about if you do a duodenojejunostomy is that you're basically leaving sort of a blind loop. And you can have problems with that. And that was documented when I was a resident years ago. People used to do a duodenojejunostomy and then got away from it because of problems. So I'm a little concerned that people are doing a duodenojejunostomy laparoscopically because it's easier, but I think you should, there's no way to do it, I would always do a duodenostomy. You're just asking for problems, leaving a piece of bowel that might just be sitting there and in kind of a blind loop syndrome. So I always do a duodenostomy unless there's just no way to do it.
Okay, Isabella, do you want to keep on, or?
Yes, of course.
Okay.
First of all, I would like to congratulate Professor Steve Rothenberg for his very accurate and explicit presentation, and to assure him we are so lucky to benefit from his huge experience. Thank you very much again. And now I'll take the next question from the chat. Some colleague ask you, for type 1 duodenal atresia, what's your preferred option of anastomosis? Side to side, or just duodenotomy, resect membrane, and duodenoplasty?
Yeah, I do mostly, you know, a side to side. I think, I mean, in cases where you do have a web, you can go in and resect the web and then do you know, do sort of a tiny caviculates type of closure. But I think it really depends on, if you're very clear you have a web, I think that's great. I think you have to be careful that you don't want to risk injuring the papilla or the bile ducts. And I think if you don't clearly have a web that you can resect, you're taking that in the risk. And so a duodenostomy, I think, is probably the safest way to go.
Yeah, I agree. It's very difficult to find the exact place of the web sometimes, to be just in the right place to do the resection. We tried with endoscope, and it's really difficult. So I think it's in the, you have to look to the embryology and go to the second part of the duodenum. Is most of them there, but it's really tricky sometimes. Thank you. There is a question about regarding the use of ICG, and we had a couple of days ago a webinar dealing of that. But the question is it really safe in neonates? What do you think?
Yeah, so I mean, we're getting more and more experience, and so we're now using it in a lot of our cases where we're questioning bowel perfusion. So there's a big series of, actually, one of the biggest series is out of Boston. Those are not so much in neonates, where they used it for esophageal atresia. We're using it now in cases of ischemic bowel from neck and volvulus. We're using it in our esophageal cases. As I mentioned, we're using it in pull-throughs. And I think it is safe. I think, in the micropreemie, maybe not. Well, I don't know. I don't know that it's not, but I think in a full-term infant that it is safe. And there are guidelines out there right now. And in fact, Juan, as you know, there's been a consensus statement written, and hopefully will be written up in the Journal of Pediatric Surgery. But we're using it more and more, and as the equipment is now more available to us on a regular basis, I think it will. And we just have to learn. I think we may avoid some of the problems where we have leaks or complications, either in esophageal surgery or bowel surgery or pull-throughs, where the bowel's more ischemic than we think it is. And so we know maybe to take a little bit more.
Yeah.
Thank you so much. Another question from the chat is, in case of a congenital diaphragmatic hernia, if you need a mesh, would you convert it or not?
So it depends on the size of the defect. If they have no diaphragm, the size of the defect and your skill. If they have basically no diaphragm, yes, there's no point in trying to sew in a mesh. I think at that point, do what's best for the baby and best for long term. I think, if we have a moderate sized defect, then yeah, I'll put the mesh in and sew it in thoracoscopically. There are much different techniques people have talked about, but I think it depends on your skill level. What you don't want to do is do a closure that's overly tight, under a lot of tension. And I think people have a hard time sometimes recognizing that thoracoscopically. If you think it's too tight, it's better to put in a patch and let it balloon a little bit so that you have a less risk of recurrence.
Yeah, another person asked also about the type of patch you use, what is the best patch for you, what type of it, and how do you fix the patch to the diaphragm?
Right. So I still use a Gore-Tex patch. Some people do an onlay. They use a combined bio patch and then a piece of Gore-Tex. I've just had good luck with Gore-Tex. And I tend to do interrupted sutures with a non-absorbable stitch, either Ethibond or Prolene. And then there are special tricks to use, like if you don't have any lateral diaphragm, you need to make sure that the stitches go around the rib so that the patch doesn't pull away from the rib. And so there are different tricks we use for that.
And regarding the same topic, somebody asked you, have you ever done congenital diaphragmatic hernia through abdominal approach?
I started that way because I was worried about the baby already being compromised from a pulmonary standpoint. The problem with doing it laparoscopically is, and we'll do older patients that way sometimes, or redos, but is that once you pull the bowel down into the abdomen, you lose all your abdominal domain and you can't see. And so, and the lung is already small on that side. So again, remember, you don't need a lot of CO2 because the lung's not going to be in your way because it's already small. So it's just a matter of reducing the bowel. So I don't think you really compromise their pulmonary function. So the first ones I did were laparoscopic just because I was more comfortable with that approach, but we do them all thoracoscopic now.
Yeah, I agree. I had only done 2 by laparoscopy, and most of our approach are from the thorax, but special situations. So there is one question, another topic regarding your 5 millimeters stapler instrument. There are people that are asking how to get it, what is the way to obtain, to what is the name actually now, and to ask for it.
So the company was initially called Just Right, and the stapler is still called Just Right. The company is now owned by a company called Hologic. We are getting distributors all over the world working on it. So the best probably would be just for people to email me, and I can forward those requests onto the company, and where we have distributors, we can have them get hold of the surgeons, or at least, and then we can show there's an interest. I don't control any of that anymore, but my hope is that it will become more and more available throughout the world.
Yeah.
Regarding the laparoscopic instruments, somebody asked you, do you use flexible laparoscopic instruments? If yes, which are more useful, straight one or flexible one, in your opinion?
Yeah, I don't use any flexible laparoscopic instruments, although, the 3mm are more tender, so they can be flexible if you bend them. But I think, I use straight shafted instruments, and none of the instruments I have a wrist. There are, I don't use robotics because the robot is just too big for this, but there are now robots coming out that are accommodating 3 and 5mm instruments and will have wrists. So that may change, but right now I use straight shafted rigid instruments.
This is a question from myself. What is your next innovation?
A new knee. Yeah.
Good.
I think AI is and advanced imaging are going to be the next thing. I think that the ability to onlay onto our screens structures that we can't see. The basic is like just using ICG for a gallbladder, which normally I don't ever do, but I did a case the other day. It was a big, heavy 90-kilo, 15-year-old who had common duct stone. And there was so much fat there, I really couldn't see his ducts. And when I put on the ICG, they became very evident to me. It became much easier to dissect them out. But I think, eventually I think we'll have an onlay that like a pulmonary resection, that you'll just push a button and suddenly you'll see where all the vessels are. So even if you have an incomplete fissure, you'll know where the vessels are. That makes it easier and safer to do. And that then the AI, if we do use more robots or whatever, will keep us from cutting the wrong things, So I think that's what's coming. I hopefully it won't, I don't think it'll come really too much during my lifetime, but I think a lot of the advanced imaging will.
Yeah, for sure. There is a couple of questions. The last ones. The one is, what is the future of colorectal surgery with minimal invasive surgery? Do you think there is anything new also in colorectal surgery, or?
Well, I think, I mean, there are some great colorectal surgeons and certainly people who have more experience than I do. I think, and the other thing that's changing is that, I became a pediatric surgeon because I like to do everything. So, but like I don't do complex cloacas anymore because I think there are people who do them much better. And I think there are some very, certainly Marcela Baez has led the way in doing very complex procedures minimally invasively. I think still too many procedures are done open. Like I said, I think too many pull-throughs are done, transanally, where I think it's much better to do it laparoscopically. And I think as the equipment and the skills build up, more will be done that way. I think we'll have better results. And then I think a lot of the straightforward anorectal malformations can be done minimally invasively as well, like using the stapler on the fistula. So I think we'll see changes in that. But I think, what's happening now is most big centers just have a colorectal team. So it's very limited to what they do. So I'm not sure how things will play out that way.
Another question for another topic. It's about the port sites in middle and upper VETS lobectomy. Could you detail?
The port size in
Port
lobectomy?
position,
Oh,
and
Yes.
port position. So I didn't, sorry, I didn't show it. Let me just see real quick. I don't remember if I didn't. So anyway, one of the things I think when people do a lobectomy, so my first port is basically in the sort of in the posterior axillary line to the mid-axillary line in about the fifth intercostal space. So much more anterior than most people put it. Most people put it near the tip of the scapula. And what happens, since I operate standing at the patient's front, if you put the port too far back, you end up looking back on yourself while you're trying to operate in the fissure. So I think the camera port needs to be more anterior, almost to the mid-axillary line. So you're looking down on the fissure. And then my operating ports are in the anterior axillary line above and below that port. And if I'm doing an upper lobe, things will migrate up a little bit. If I'm doing a lower lobe, they might migrate down a little bit. But I think the biggest mistake people make is putting the port too far posteriorly.
okay, I have to ask to our host, Professor Zehata. Do we have 5 or 10 more minutes because there are coming more questions? What do you think?
Well, I think Steve has succeeded to stimulate the people to shoot a lot of questions. I think I would not disappoint them. We can continue with 5 more minutes.
Thank you.
Thanks, Sammy.
Next question. For ligation of TF, would you prefer clip or suture? If suture, what type of suture is recommended? Does clip ligation has potential risk for refistulation?
Right. So 2 point. I use a clip because I haven't had a problem with the clip, and it's the quickest way to get control of the fistula. And I use a 5mm clip. Unless the baby's under 2.5 kilos, then I suture ligate it. Some people have talked about the clip migrating. I've never seen that. I think what happens if the clip migrates is that they probably injured the fistula or the back wall of the trachea, and then it erodes in. But what you want to do, the biggest way you can help the anesthetist when you're doing a TF procedure is get control of that fistula and ligate it so they quit losing their tidal volume down into the stomach. But suture ligation is fine. And when I suture ligate it, and again, if the babies are smaller than 2 or 2.5 kilos, I use a PDS suture. And I just suture ligate it. But again, make sure you're right on the back wall of the trachea. You don't want to leave a big fistula there. And the other thing is, if you have a baby that's not tolerated, never go in and just ligate the fistula and then get out thinking you'll come back later. If all you do is ligate the fistula and you don't divide it, the fistula will recur. It doesn't matter whether you use a suture, a clip, or whatever. I've done that experiment. It doesn't work.
Okay. What kind of simulation training exercises do you have for your fellows or residents to gain competence in these children, these small
So
babies?
there are better people to ask than me to that, but there are some great models out now, and a number of our colleagues have made great little trainers that are really fairly inexpensive. Carolina Molina and in Buenos Aires has a great trainer. Basically, there are some very fancy courses that we use, high fidelity models, even tissue models, and those are great if you get to take them. But mostly what you want to do if you're training at home is get practice working in a small box with a camera, and you can even use your iPhone to do it if you have the instruments. And I think the best thing to do is I think you can contact both IPEG and ESPES because I think both societies know about models that you can order and get for not very expensive.
Now a question related to congenital diaphragmatic hernia with big defects. Some colleagues ask you, sometimes double face mesh and expensive ones are not available, and all we have is Prolen meshes in some deprived areas. So, do you have experience with Prolen mesh alone in congenital diaphragmatic hernia with big defects? And what are the long-run effects using this kind of mesh?
So I have no experience with Proline mesh, but I think, as always, you have to deal with what you have. So if that's what you have, I I think that's fine. You know, some people would say, well, if you don't have a good mesh, then maybe you should do a muscle flap, you know, and from the lateral internal oblique or something and bring that up. But I don't have any experience, so I can't really say.
And do you always, this is another question, different. Do you always ligate the thoracic duct in case of a post-operative chylothorax? Or how do you manage?
I never ligate the thoracic duct unless it's leaking. But
Yeah.
if you do have to go after a thoracic duct, ICG, that's an amazing case because it lights right up. You can see right where the leak is.
The next question, the use of MIS in post-neck patients. What difficulties or complications have you had? Wouldn't it be technically difficult to approach in this patient with a high probability of an adhesion process?
So again, it's sort of your skill set. You know, I think some cases are amenable if it's like a walled off perf or a stricture. There's usually not too many adhesions. You know, the time you get adhesions are when you have, you know, you've had an open perf and wide contamination. And those cases probably aren't amenable to laparoscopy, or at least I don't do those. But in those where you've had neck that's treated medically and then you get an ischemic stricture, there's usually very few adhesions in those cases. So it's just a matter of your comfort level operating in the small abdomen of a baby. And you just, you know, each center needs to decide how small they're comfortable operating on.
And the last one, this is the very last one question. It's from run by Ray that asks you if there is any device for single incision surgery in children, if you know or you have experience.
Well, there are, I mean, there are ports out there, you know, a couple different companies, Applied Medical, I think Medtronic have ports that allow for multiple things. But honestly, I think, so like when I do an appendectomy, I do it all intracorporeally, but I put 2 ports in the umbilicus. I put, you know, a 4 and a 5. So through 1/10 centimeter incision, a 1 centimeter incision in the umbilicus, I can put my camera in one instrument. And then I usually put a 3 millimeter in the suprapubic area. I think 3 millimeter instruments leave such small, you know, footprints, scars, you can't often see them, that there's not a big benefit to trying to jam multiple ports in a baby into the umbilicus. I would rather have at least one separate 3 millimeter port so that I have the right angle, the 90 degrees that I need to do complex things. So there are some very good skilled single port surgeons. You know, Mac Harmon has pushed this for a long time. I'm not that good, so I like having a little bit of a right angle, and I don't think a 3 millimeter instrument really provides any significant scar, and I'm better and quicker with that. So I'm not a big fan of, I was one of the first to start doing it, but it's just very difficult when you have your instruments dueling all the time.
Okay, I think we have done most of our questions and we are on time. So thank you very much, Steve, for your talk and your answers. We enjoyed a lot, and thank you. I hope to see you soon.
Yeah, well, thank you guys for having me, and I look forward to seeing you soon. Take care.
Thank you
so much, Steve. Actually, you had a wonderful talk about an overview of the most challenging situation of neonatal MIS. You have shown wonderful examples, but this was a quick overview. So maybe, Steve, we need a promise from your side that you're going to give detailed description of each one of these techniques. We had almost over 100 of the members attending, but many of them couldn't join, so they asked for the recording. The good news, we have the recording. It will be put on the ESPES website, so that will be available for members only. I would like to thank all the candidates who attended today for a wonderful interaction. I would like to thank the leadership of the ESPES, Juana and Isabella, for excellent support and moderation. Thank you so much, and wait for our next episode. Thank you.
Thank you. Bye-bye.
Thank you. Goodbye.